decrease of income coming into the home. They're afraid of losing their health insurance. They're struggling with accessing public safety net programs out there because they're being inundated with calls. And so many of us are experiencing what it's like to be a cancer patient at this point from a financial toxicity standpoint. And I hope that as we get on the other side of COVID-19, I hope that we pay attention to this and improve this issue of financial toxicity, just because we probably understand it at a much deeper level now, because we're all going through this experience as well. Let me just briefly talk about, some of the psychological implications of financial toxicity. And once again, we're seeing this play itself out across the United States right now. When there is a significant decrease of income coming into the home, there's a huge threats occurring to their well-being. One of the best ways I've been able to explain this is the Maslow hierarchies. I mean, he put together this model of saying, how do people experience wellness in life? And he said, well, your physiological needs need to be taken care of in order for a person to be able to experience wellness in life. And the category of physiological needs does not just pertain to the person's medical diagnosis, right? When you're diagnosed with cancer, your physiological needs are being threatened immediately. But there's other components to physiological needs, which is food, shelter, transportation, warmth, rest, all of those things that we have to protect ourselves. Once those issues are threatened, there's significant amount of distress that the person is experiencing. Once again, unfortunately, a lot of Americans are going through this right now, is how do I pay my rent with a significant decrease of income? Can I keep the utilities going? All of these questions. Now, I do understand that the national government and the state governments are doing what they can to help people through this. But that doesn't take away the amount of distress that our patients are experiencing. If we move up to the next category, safety and security needs, there are huge financial components to this, right? We who are employed, we put money into a 401k or an IRA or some type of retirement account to make ourselves feel safe. And what happens when you're diagnosed with a major illness and you have a significant decrease of income into the home, usually people stop putting funds into those retirement accounts, or worse yet, people are taking money out of those funds to be able to get through their basic needs and be able to pay for their basic needs right now, or even their medical care. Once again, we're seeing the same thing play itself out here with COVID-19, that many people are stopping their 401k investments. They're withdrawing money out of there because they need those funds. One more, I'm going to bring it up one more level here, belongingness and love needs. Dr. Safar out of Duke Cancer Institute, who's done a lot of work on financial distress and financial toxicity. In one of his studies, he found that 24% of the population that he studied suffered relationship problems secondary to the financial distress that they're in because of their cancer diagnosis. So my wife has a cousin who is a police officer in the town that we live in here in Grand Rapids, Michigan. I called with him the other day and asked him, hey, are you busy right now? And his answer was, are extremely busy. Domestic violence is going through the roof. And so call after call is occurring because financial distress is occurring. I mean, it's probably I can't say it's the only reason, but it's one of the reasons why domestic violence and domestic abuse is occurring. The number one reason why people are in prison is because of socioeconomic reasons. And so I'm just trying to paint the picture here that when people experience financial toxicity, it has huge implications not only on their medical needs and their medical treatments, but huge implications on the emotional, psychological well-being of that individual. So a couple of statistics here that I want to point out. 27% of insured cancer patients report non-adherence to treatment secondary to cost. In regards to health insurance premiums, right? So Kaiser Family Foundation reported back in 2019 that commercial coverage, right? So if you're employed through an employer, they provide coverage to you. The cost of that policy for a family right now is over $1,000. And let's just think about this for a moment. Millions of Americans are being laid off. Some of them are going on furlough, some are being laid off. But if these policies are costing $20,000 a year and these individuals are being offered COBRA, that individual, if they want to continue the insurance that they have through the COBRA system, it's going to cost them approximately $28,000 for a year. And I think it's a fair assessment to say that most Americans are not going to be able to afford this. And so now there's a huge risk of people becoming uninsured. We do understand, and I'll give you a couple of examples of the ACA here and how the ACA is going to fall into the category and what they can do to be assistance. Individuals who can enroll into the ACA because of the special enrollment period due to loss of coverage. For many of them, it will be affordable for them to purchase insurance. For many people, it will not be affordable because your premiums are based upon your income. And if there's not a significant decrease of income coming into the home, then those premiums are going to be extremely expensive. In regards to distress and anxiety, I know this is an old report here in 2009, but I think it's important to understand this date. This study came out in August of 2009, which says that cancer patients demonstrate more anxiety over the cost of treatment than dying from the disease. Well, what happened in 2008 and 2009? We had a significant economic, depression. We had a huge economic fallout, and prior to 2009, when they asked this question, it was dying from the disease was the number one stressor. What I'm trying to point out here again is that when financial distress occurs, it has huge ramifications on the well-being of the individual. And then the last month, survey found that, I can't see it here because the video is in the way. I think it says approximately 90% of individuals want to talk about the cost of treatment, but only 14% of them have had a conversation with somebody within the oncology setting about cost of treatment. So there's a huge need huge needs out there in regards to patients wanting to talk to somebody about this issue of financial, or talk about the financial implications of their disease. And as an unmet need, 14% in this study found that they actually ended up having that conversation. One last one here, 2018 study found that there is a correlation between cancer-related financial toxicity and quality of life. So the high cancer or the financial toxicity that the patient is experiencing, the lower quality of life scores they are reporting on those questionnaires. How have we in the healthcare system attempted to deal with this? Well, throughout many years, dating back 30, 40 years, hospital systems have always had financial counselors in place to address this issue of financial toxicity or financial distress. But in general, most hospital financial counselors, their specialty involves enrolling people into Medicaid and enrolling people into their charity programs. Approximately, this is throughout the United States, approximately 20% of the population qualifies for Medicaid. So what are we doing with the remaining 80% that are out there who don't qualify for Medicaid and are experiencing a huge financial burden? About 10 years ago, financial advocates started springing up within oncology programs. And usually this starts through the social work department, maybe case managers, but usually social workers within the healthcare setting are going, there are many more programs out there. There's charity and Medicaid for people. There's copay assistance programs, patient assistance programs, premium assistance, lots of programs out there that assist with basic needs. Ray, you mentioned some of these here, HealthWell, Cancer. There's another one, PAN Foundation, just opened up a 19 fund. It's about $300. But these copay assistance programs out there help with the patient's out-of-pocket responsibility for a specific pharmaceutical product, or the PAP assistance, right? Social workers and financial advocates can get free infusions products, you know, if that's Opdivo, Keytruda, Herceptin. Pharmaceutical companies hand out these products for people who have no coverage or are struggling with their out-of-pockets for it. So that fixes the component of the infusion services, but it doesn't fix all of the other medical expenses that this patient is experiencing once they're diagnosed with cancer. There are no copay assistance programs or patient assistance programs for radiation treatments or for surgery or for the emergency visits or for the PET. And so when we focus only on doing advocacy, for example, copay assistance and patient assistance programs, the patient still struggles with out-of-pocket responsibilities for their care. And so this is where financial navigation can have a huge opportunity to make a difference, because it takes a look at navigating the patient through our complicated healthcare system and making sure that as they are enrolling into health coverage, that they're enrolling into the proper coverage that meets their needs and their financial needs and their medical needs. So let me, I'll give you a couple of practical examples of this needs. So what's the approach that financial navigation takes? And I've just used this acronym of TREAT. It is extremely important that we as healthcare providers start understanding that we need to treat financial toxicity. It's not just an issue that we're going to refer down to the financial counsel office and see what they can do. We need to take a very proactive, advanced approach here. And it starts with recognizing that the financial navigator is part of the team, right? In many healthcare settings, the financial counselor is located outside of the oncology program. Not in all, but in many of them they are. And so that financial counselor often not aware of what's going on. They don't understand the treatment options that this patient has. They don't understand the side effects of all of the treatments. How long is this person going to be in treatment? A good financial advocacy or a good financial navigation program, we're going to place the financial navigator in the middle of the treatment team, so they have full access to what's going on with, you know, what kind of coverage they have. Investigation process has all the prior authorizations taken care of, understanding what the clinical needs of the person is, right? So a person that comes in for early stage prostate cancer is going to have very treatment needs, as well as the financial consequences of this disease is going to be very different between a patient with prostate cancer versus somebody with multiple myeloma or, you know, stage 4 breast cancer. A person with a glioblastoma is going to have very different needs than somebody with cancer that needs a lumpectomy followed by radiation treatment. So it's critical that the financial navigator understands the clinical needs of this patient, and then gather the appropriate financial navigation based upon, you know, how long is this person going to be in treatment, what are the side effects of the treatment. That's looking at optimizing coverage, and then external assistance programs. So let me see how much I'm doing. Okay on time. I'm going to ask a quick question that I want you to think about. So, a person approaches a piano, right? Let's say you were a parent said, "Hey, we want to play the piano." You remember you did to be able to learn how to play the piano? Well, you had to learn the scale, right? I'm not going to sing the scale because you turn off the computer. But you practice the scale over and over and over again, right? And then when you practice that scale in a key, and you learn on all of the keys that are available on the piano, right? And then you started incorporating your left hand and learn the scale left hand and learn the scale in all the different keys in the hand. And then you started putting them together. And it's the same financial navigation. The picture that you have on the screen right now, the slide here, is a scale for financial navigation. The financial navigation is to master all of the external, master what are the government safety networks, not just, hey, I know Medicaid is for people, I know that social disability is available for people, but actually understand at a deep level, understanding how does the low-income subsidy program work and the Medicare savings program work, and use them at the appropriate time. Can you use programs? Under what circumstances can you use them? So that when the patient meets with you, you don't just say, "Oh, I think you're going to qualify for this," when you go and apply. No, that you are a master of this, and you know who qualifies, who doesn't, and then help the patient with the enrollment process. And then also the same thing with health insurance policies. Really understanding people, how does Medicare work? How is it put together? When can you enroll into specific supplemental policies, Medicare Advantage plans? When do you do D? When should you not do D? Same thing with the Affordable Care Act. It's wise to enroll into the Affordable Care Act if you're going to. Sometimes the answer would be yes, and the answer would be no. All I'm trying to say here is that the financial navigator needs to master these different components here in order to provide effective financial navigation for the patient. So let me just give you an example. Here's a patient, this is the ACA. So here's a patient who enrolled into an ACA policy. She came into our healthcare setting. She was diagnosed with a fairly aggressive lymphoma. It was the month of April, so it's not open enrollment. When in our setting, we see all new consults. We want to make sure that the financial component is being looked at. So I saw this come across my desk, saw a bad diagnosis. In this policy here where she had a $7,000 pocket for her care. So on the day of consult, I went in and met with the patient after the physician had explained what the treatment plan was going to be. I'd also spoken with the physician to understand what the treatment plan was going to be, which is going to be at least 6 months of treatment and most likely not able to do treatment due to the serious side effects of the chemotherapy treatments. So I met with the patient. She indicated that she had a short-term disability policy available to her at 60% of pay, but did not have long-term disability. So and she purchased this policy in the ACA. The way you purchase policies is that during open enrollment, you have to tell the state or the government what your predicted income for the year is going to be. And she had told them right around $54,000 for the year. She's single with 2 children. So based upon her household size and her income, this is the policy that was offered to her. She's paying $1,003 a month for it, has a $3,300 deductible and a $7,300 max out of pocket. But because she had a significant decrease of income, right? She's going to now start receiving 60% of pay. Her income went down to right around $37,000 for the year, which means that the policy that she has in the ACA is no longer appropriate for her because her income is not reflective in this policy. So when that occurs, when there's a significant decrease of income coming into the home, it actually generates an open enrollment period within the ACA that you can change your plan based upon that significant decrease of income. So on the day of consult, we contacted the marketplace together and informed them of the significant decrease of income. And after we did that, I wanted to observe the out-of-pockets and the premiums that this patient has. This is her new policy. She's paying $231 a month, and her out-of-pocket went from $7,000 down to $2,400. Now, when you think about an individual who has a new cancer diagnosis, is overwhelmed, has children in the home, and has a significant decrease in income coming into the home, can you imagine the amount of financial toxicity, the emotional component that she is experiencing going through this? And what is it like now to, rather than having to get $1,000 a month in premium, she's now paying $231 a month? I would argue that knowing is made here, her insurance was at huge risk of being terminated, because I would suspect that she would struggle with paying $1 a month premium. Now, in this specific case, because she was diagnosed with a lymphoma, I also enrolled her into LLS, Leukemia Lymphoma Foundation, and they, by the way, help with premiums. And so we got LLS to pay her these health insurance premiums for $231. She was granted $2,500 from LLS. So if we would have not done this intervention, she would have run out of premium the system LLS in month number 3. This way, the $230, we had LLS pay these premiums for the entire duration of her treatments. And we also did the assistance program to help with the $2,400 as well. Some of these same issues here play here. 50%, and these are national numbers, but 50% of Medicare beneficiaries fall below 200% of the federal poverty levels. Of your Medicare population has an extremely low income, and the average cost of treating a cancer for Medicare beneficiaries, the average cost is right around $5,700. $5,700 in out-of-pocket responsibilities for Medicare beneficiaries is a mountain when talking below 200% of the poverty level. So are there some things that can be done in regards to insurance optimization within the Medicare system? So here's an example. Here's a 67-year-old married male diagnosed with metastatic melanoma. Monthly household gross income is $1,680, and they have $11,000 in assets. He has Medicare A and B only. He is not enrolled in D. So the problem here is that he has an unlimited 20% for his care. Total cost of income for 1 year was estimated to be $380,000 after the Medicare allowable. We estimated his responsibility to be $44,000. Obviously, he is not able to pay that. So what would happen here is that if a financial counselor got involved, that financial counselor would do one of two things. Either provide charity for the individual, which would be very beneficial to this patient, or try to get him into Medicaid. When you have Medicare, there is an asset qualifier for Medicaid. Most states in Colorado expanded Medicaid, so there's no asset qualifier in Medicaid expansion. But that does not transition over to Medicare beneficiaries, right? You still have to have typically it's less than $2,000 in assets. So a well-intentioned financial counselor would say, well, let's try to get you Medicaid. You're going to have to, your $11,000 in assets need to go below either $3,000 or $2,000, and then we can get you Medicaid. I wonder what Maslow would say about those $11,000 that this person has, or this couple has in assets. $11,000 is not a lot of money, but it's a lot of money for them. It's a security limit. And here, a well-intentioned financial counselor is going to say, let's try to get rid of it so we can get you Medicaid. I'm going to argue that there's a much, much better way to go in this type of a scenario. And that is, once again, can we do insurance enhancement? Can we improve people's insurance? So in the medical system, if you understand it, if you've studied the scale and you've measured the scale, the first thing that we would do here is enroll into the low income subsidy program that Medicare has for Medicare D. Remember, this person does have D, but that doesn't mean that we can't enroll him into low income subsidy. What happens is when this person gets approved for low income subsidy, it will allow him to enroll into D, but it will allow him to enroll into an Advantage plan. In some states, you can also go into a gap policy, a little bit more difficult than that, but this area, we enrolled him into a Medicare Advantage plan. And what's the difference between having Medicare only and Medicare Advantage plan? Well, Medicare only, you're paying 20% for care, and there's no max out of pocket. With Medicare Advantage plan, at least you have a max out of pocket for the year, and so, usually they are in the $4,000 to $6,000. I'm going to argue that $4,000 or $6,000 better than $44,000. Because of the LIS approval, he can enroll anytime during the year into a Medicare Advantage plan and get the benefits. Now that we've enhanced the insurance, now look at all of the external assistance programs out there. So enroll him into co-assistance for his specific diagnosis that can help with his $4,000 to $6,000 max out of pocket. So if possible, enroll him into premium assistance if there's something out there that can do that. And then enroll him into the savings program. He qualified for a level 2 SP, which where the state pays the Medicare Part B premium for him, and because he's married, his wife qualified as well, and so now all of a sudden, about $280 more a month is coming into the Social Security check, which once again is a lot of money for somebody with this type of low income. This intervention saved the patient, and I can't see it on my screen because the videos are in the way, but I think it's right around $44,000, and it saved savings to the provider of $44,000. Medicare Part D, I'm not going to spend a lot of time on this just due to time issues here, but for people who are in the Medicare system, Medicare Part D has significant problems. And this is where that low-income subsidy program is essential. It's approximately 30% of all Medicare beneficiaries qualify for extra help. And according to the latest data that I've seen from SHIP organizations, is they estimate that approximately half of Medicare population who qualify for LIS are actually enrolled. So it's a highly underutilized program, and mostly because financial advocates and financial counselors are just not aware of this program. Why is it important? Well, here's a patient, prostate cancer, standing. That drug cost $11,000 a month. Yes, copay is right around $2,200. When you fill an $11,000 medication, you go through your initial coverage gap, you end up in catastrophic coverage in month number 2, and then you pay 5%, so that's $568. I think I meant 50% of Medicare beneficiaries fall below 200% of the federal poly levels, so that's very difficult to pay that. This person is enrolled into LIS. This person happened to 4 different levels of LIS. It went from $2,200 down to 50 cents, and then in the same month, these medications, his copays are free. By the way, all his other medications that he's on as well, the same occurred with. If we only focused on copay assistance here, or get free drug from the manufacturer, it doesn't fix all of his other copays that he has with his other medications. Now we've done insurance enhancement, insurance optimization, not focusing on optimizing external assistance programs. Now I spend an hour just on this slide, which I obviously don't have time to do. this is another critical component, making sure that after insurance optimization, we're optimizing all of the different assistance programs out there. Rachel, you mentioned some of them here in the beginning, health, well, and cancer care. You also mentioned these patient financial support programs today. There's the Ping Pong, there's Family Reach, there's lots of organizations there with some of the more day-to-day living expenses that cancer patients have. Why is having a good place to enroll people into co-pay assistance programs important? Well, here's just a slide. This is a software program called Viver. If you look on the bottom here where it says Patient Advocate Foundation, they pay up to $8,500 in assistance a year for non-small cell lung cancer, but it's currently closed. What I want to point out is that it goes retroactive back 180 days. So have a good system in place, then this fund opens up. So maybe you've been in treatment for 3 or 4 months. You still want to enroll people into these foundations because many of them go retroactive back a significant portion of time. One more thing here in regards to understanding Gail. Here's a patient that came in, and he was getting Xtandi for free from the manufacturer. So the health system that he had gone to for his prostate cancer said, hey, you have paid co-pay for cancer rather than you paying this co-pay to the company, they're going to provide it for free. So he was happy about that, but when I met with him, he says, I'm struggling with all of my other co-pays from my other medications. So here's the Humalog and the Xarelto. He's paying $130 and $110. And I told him, well, one of the reasons why this copay is so high is because the Xtandi for free from the manufacturer. If we filled your Xtandi through Part D, it would put you into catastrophic coverage. And by the way, we need to use a copay assistance program to fix this for you, which there was one open when I met with him. So I enrolled him into a prostate cancer copay assistance program that paid his $2,800 copay for Xtandi, but that puts catastrophic coverage in the next month. So now, when he goes and fills his medications through the pharmacy, his other medications have gone way down in price. Lower income for LAS, so this was the more tactical approach here to fix his pockets with his current scenario. A well-trained financial navigator would be able to use these type of interventions to help, once again, lower the financial toxicity for the patient. There is significant return on investment for the hospital system. Here's a hospital system that implemented the program. This is a capture of the year. This was 2017. The return on investment for this was over $3 million. They saw just under 2,000 new oncology patients per year. If you can look way down the bottom right-hand corner, there were support. The benefit to the patient that were going through their system was over $8 million. Training opportunities out there. So the Association of Community Cancer Centers, ACCC, does have something called the Financial Advocacy Boot Camp. A number of ACCC, you can go through for free. There are, every state has SHIT programs, state health insurance assistance programs. Some of those programs do provide some education in regards to Medicare and Medicaid. You guys are going to be hearing from Triage Cancer do some and then my specific, I'm not trying to sell a product here, but my specific program is I train the individual in how to do these interventions and 16 hours of training, followed by a minimum of 12 months of remote support. It's 12 months of mentorship for developing their skills. Last thing here, and then I'm going to take some questions here. Touch Cancer Institute has done a lot of work in regards to financial toxicity. And they took a look at 4 different hospital systems that had implemented this program. And then they evaluated the data, and then this article was published in the American. So if you're interested in this article, email me, and I'm happy to email you the article as well. In my opinion, financial navigation can support improved access to care. I'm going to argue strongly that it reduces financial toxicity, it reduces bad insurance, it will increase your patient satisfaction scores. And then that I think is pretty important is that it reduces workload for mental health services. I can tell you, it was really interesting. When we implemented this program, administration very quickly saw how beneficial it was, and they wanted to hire a financial navigator. And so they took an FTE from social work and put it into financial navigation. The social workers were quite upset about that when that occurred. 1 year later, they came back to me and said it was a decision. Our caseload has significantly gone down, specifically when it relates to financial toxicity, and all of the referrals that they would receive due to distress because of financial reasons. And so, not arguing that your health system should do that, but I am arguing that this does impact mental health services as well in your healthcare setting. All right. We have about 15 more minutes. Questions if there's anyone that have been posted. Jenna.
Yep, thank you, Dan. That was an excellent presentation. I invite you all to either take yourself off of mute or type your questions into the chat box. As of right now, we don't have any questions, but please feel free to ask Dan any questions you may have.
So maybe while we're waiting for a question, Rachel, can I put you on the spot? You went through this training as well, and can you talk a little bit about the learning curve? As training is one thing, but I tend to argue that when you go through this training, you're this much of an expert, and it's actually implementing and putting in practices that you're actually learning. Are you comfortable sharing any of that?
Sure, no, I agree. I mean, the training is absolutely invaluable. All of these things I think that we're doing to help patients are resources that are out there, but they're just not able to find them. I think the main piece is that the financial navigator, as you said, knows all these different facets of it and kind of can piece things together to create a strategy. So definitely, I think that just actually working the cases, getting the patients, and going through doing the analysis and looking at all the different possibilities now they piece together is definitely the best. Experience is always the best teacher. But I think. Also with the training that we did with you, I think it was really important that we went through some case scenarios. I don't know if those were hypothetical or real ones that you gave us, but it helps you figure out what you don't know.
Right.
and was definitely, so definitely learning on the job. And I think that, in talking about, I've had some people ask me, what would the qualifications be for a good financial navigator? And I don't know in terms of, education experience, but I know that in addition to the training, just having critical thinking skills, analytical thinking skills, I think what I found is that that's probably the biggest piece, is just being able to do that.
Right. I'm going to add in another quality that I think is vital for the National Navigator to have, and that's passion. This stuff is complicated. It's not easy work until you've learned it. And the other problem is that rules and regulations are constantly changing, right? And so insurance policies are changing and access to care is changing. And so if you don't have passion and not keeping up with all of the changes that are occurring, you fall behind very, very quickly. The more I do this and the more I provide training to hospital systems, it's just critical that that financial navigator has a passion for it, but I also want to say they have the ability and the strength to do work on their own. Most managers and directors in most health systems don't understand this financial navigation at the level. They understand financial counseling, right? Charity and Medicaid. So many times the financial navigator, or sometimes they're kind of out there by themselves and they're leading the way. So it takes a person who is self-motivated and has that strength to be able to implement it within their system after they've gone through the training. At least that's been my observation.
Absolutely. And since I don't see any questions popping up, one question that I get from people a lot that maybe you can address, Dan, is how do they get started? So oftentimes it's maybe a social worker who's just, one person within a large organization who really feels the frustration. I think that's what your history is as well, is just seeing
Right.
this a lot and not really knowing what to do, but knowing that, there are programs out there. How would you suggest they get started or make the case, to leadership, or just if you had any advice on that?
Sure. Well, I think one of the most important things, as if there's a social worker or an advocate within the system, one of the most important things that that person should do immediately is to track the work that they're doing. Start showing the return on investment. I go back to this slide right here. This slide is just critical in order for the people who make the decisions about the role to say, okay, we're going to invest into this role. It's easy to say, well, the return on investment is very significant, but you need to be able to prove that. And so, start with simple stuff. Start with enrolling people into copay assistance programs and patient assistance programs. And you'll see some significant numbers immediately. Now, I tend to argue that those systems, if you're just doing those in isolation, you're putting Band-Aids on the sore because they're flooded with medical bills from many other sides. And so, but once you've developed those skills, start looking at, how can I help people with Medicare? How can I help people in the ACA? And things like that. So, but the most important thing to do immediately is start keeping track of the work and showing the financial value that has to the patient and the provider.
Thanks, that's good advice.
So we do have one question. As a cancer patient, where can cancer patients find financial navigators?
Yeah, that's a good question. Unfortunately, there are no federal or state guidelines in regards to, first of all, hospitals having financial navigators in place, and then there's no certification requirements for these individuals as well. And so it's, in some ways, it's kind of the luck of the draw if your specific cancer center has a highly trained financial navigator or not. I certainly would, the first thing you should do is reach out to your social worker in your oncology program and ask, do they have a dedicated financial advocate or a financial navigator within the health system? If the answer is yes, then ask to be able to speak with that person. We are in the early stages here of developing or health systems understanding this role. And I'm somewhat encouraged that in the midst of what's going on with COVID-19, more and more hospital systems and administrators are going to see the light of how important having a qualified financial navigator in place, because once again, as I mentioned early on, we're all experiencing this right now. We're all going through the emotional experience of toxicity. So I'm hopeful that we'll see a robust financial navigation system or programs throughout the United States.
Great, thank you. Are there any other questions before we end the webinar?
So like I said, feel free to email me if there are any questions. I'm happy to answer further questions as they come up.
And Jen, where can folks find the recording of this webinar?
So the recording will be on the Colorado Cancer Coalition website. If you look for webinars, it should be up, and usually takes a day or two for it to come up, but it will be on that website. And as Dan had said, please talk to your leadership about this, have them take a look at this webinar. He just really highlighted the importance of a strong financial navigation program. We think that it's really great for everyone to really understand the resources and why a financial navigator is so essential to our cancer teams and really all chronic care disease teams moving forward. Thank you, Dan. We really appreciate your time today and your